Hello, everyone. My name is Ankit Kansagra. I'm a multiple myeloma physician at UT Southwestern Medical Center in Dallas, Texas. Thank you to the International Myeloma Foundation and the team for giving us the opportunity to share about our abstract, which looks at the cost effectiveness analysis of two novel compounds in relapsed refractory multiple myeloma, one being Belantamab Mafodotin or Belamaf or Blenrep is the trade name, and Selinexor or Expovio. The reason we were looking at this abstract or this question, the first and foremost, the most important thing which has happened in myeloma is have been very fortunate to see significant advances in the new therapies for our patients with multiple myeloma. Some of you might know from the blood cancer perspective, myeloma has surpassed all other blood cancers in terms of how many new FDA approvals has happened over the last decade. Now, the challenge has been with most of these things is these have been either approved from earlier phase clinical studies. Phase 2 studies has been the most common thing. And even though they are shown to have clinically meaningful response rates, progression-free survivals for most of them, very few studies with overall survival, one part which is lagging in all of these clinical studies, clinical trials, is the cost effectiveness. As we come to a point where we no more have the challenge of just picking one drug. Thankfully, we have two various options to choose from. The challenge now we face is how can we come up with the most cost-effective treatment alternative for our patients, which not only provide them with the best efficacy, best clinical response, but at the same time, it doesn't break their banks, right? And so this is what the main gist of our abstract is. Now, I will go on to talk about three or four most salient points. So this has been based on a Markov model. Now, this model has been very well validated in looking at quality or cost associated with life year gained. It's been out there for many years or decades. And so we use this Markov model to predict how a particular therapy would do in terms of an outcome of a patient modeled over a 12-month period. Now, we picked up that time period just because our patients in the relapse refractory time frame, we wanted to see what is happening in this 12 months of period. We, as shown in this diagram here, we kind of, our statistical team would model that what will happen to the patient. Would they respond to a treatment? Will they not respond to a treatment, or they continue to progress? In this model, what you have to do is you have to incorporate the cost of the drug, may it be an oral drug or an IV infusion. We also incorporate the adverse event monitoring and also treatment of those adverse events from any of the drugs, and kind of evaluate what would it look like. And then obviously, if the patient or an individual progresses on these therapies, what would be the next potential options? Now, just a caveat, it is always challenging because these drugs are currently approved for patients who are very refractory to multiple myeloma, especially the Belantamab Mafodotin and Selinexor as single agents. And so there is not always a great standard of care after that. So it becomes a bit harder in those calculations, but we try our best to get to those points. Now, the answer to these and just kind of narrowing down on what we found in this data set is, if I can go down here and maybe zoom my screen a little bit, it helps you guys see things better. You could notice that we looked at the quality calculations based on the survival at 12 months, 18 months, and 5 years. Now, you would argue that why do you have to look at 5 years? And this is certainly very hard to see what it is, especially for these drugs. But if you focus on the 12-month and the 18-month period, we looked at what happens if 20% of the individuals myeloma is doing well and how they survive. 50% multiple myeloma patients survive at the end of 12 months, 80% and henceforth. And what you could see here, the goal of this thing is not to just say one drug is better than the other because it is $5,000 here and there, but it is to kind of help us guide as we do our future clinical studies, clinical trials, and more provide a holistic look at how we're going to give treatment. And as you could see here, go down, if there is a 20% survival benefit, the QALY is 0.99 for selinexor at a cost of 168,000 versus QALY of 1.0 at a cost of 216,000. As you could see, if our patients with myeloma have a survival which is better at 50% survival at 12 months, then that QALY matrix look a lot different and maybe even a lot better. I will guide everybody to the ICER data, which was published by this ICER committee in May of 2021, just about a month or two ago, which looks at the CAR T cell data and also has some information on Belantamab Mafodotin. They look at in a different trajectory as what should the drug companies price the drugs for. Having said that, our goal here is to be able to understand what is the cost effectiveness at the current price of the drugs, and when you try to use this, what would be the potential benefit for your patients. So at the end of the day, what we hope to do is use this model to incorporate into future real world studies and help our patients and caregivers understand what should be the right treatment algorithm if two treatments are very similarly effective in terms of their clinical responses and have factors like quality and cost effectiveness incorporated in there. And I think that I would end here, and certainly reach out to us for any questions. Happy to answer them. My email address is right at the bottom, and I would be happy to field any questions through there. Thank you for having me again.